Good morning, everyone. Good morning. My name is Giampiero Leoncini. I am the representative of CAF Development Bank of Latin America for Trinidad and Tobago. I want to thank all the representatives of the health sector, the doctors who are listening to us now, and well, especially for all their fantastic work in these very difficult times. In Trinidad and Tobago, in Barbados. Thank you so much for being with us today. Just as a brief presentation, I would like to say that CAF Development Bank of Latin America is a multilateral institution that is committed to sustainable development and to regional integration in Latin America and the Caribbean. We have 19 member countries. 3 of them are members of CARICOM. These are Trinidad and Tobago, Barbados, and Jamaica. So we are very, very pleased being able to get to you and to tell you that our mission in these difficult times is to try to help to support our countries in facing this emergency, which is both public health emergency and an economic emergency. For this reason, we have recently approved $350 million of financial support for Trinidad and Tobago, and $100 million for Barbados. But we also believe that our assistance should not be limited to financial assistance, and that we can provide technical support where it is needed. So together with the Ministry of Health of Trinidad and Tobago, we thought that we could start a series of webinars to try to bring some relevant data expertise to share with the health sector, not only of Trinidad and Tobago, but also of other English-speaking Caribbean nations. And so we are very honored to start today with a keynote speech by Dr. Bernardo Horta. Dr. Bernardo Horta is Brazilian. He's an associate professor of UFPEL University in Brazil, has a PhD from McGill University from Canada. He's an advisor to PAHO and to WHO. He's one of the top Brazilian epidemiologists that's currently engaged in the fight against the pandemic in Brazil. So we are delighted to being able to present him and to listen to his comments to his conference today. Before giving the floor to him, I would like Dr. Mariam Richards, who is the Principal Medical Officer of the Ministry of Health of Trinidad and Tobago, to say some opening remarks also.
Okay, good morning, everyone. My name is Mariam Abdul Richards. I'm the Principal Medical Officer for the Ministry of Health in Trinidad and Tobago. I'm representing Dr. Roshan Parasram, the Chief Medical Officer, who's currently doing a media conference with the Minister of Health. Firstly, we'd like to thank the bank, CAF, for their assistance in providing technical support with respect to the national response to the COVID-19 pandemic. Of course, CAF is one of our essential partners in terms of the government of Trinidad and Tobago, given their financial support over the last few years. I think it's about 4 or 5 years. We've received quite a bit of funding from CAF. One of the incredible lessons learned thus far in managing the COVID response internationally is the role of teachings and learnings. And given that this is a new virus with a very ambiguous sort of behavior, it is to our benefit that we liaise and have technical cooperation with persons and with institutions from other countries, where there may be some successes that have been placed forward. Given CAF's goal of sustainable development and regional integration, I believe that this endeavor is one that we will continue to support at the Ministry of Health and to collaborate. And we look forward to future collaborations on any other topics that we require assistance on. Thank you very much again to CAF, and I look forward to our presentation from Bernardo, who of course has significant experience in terms of the epidemiological management of this disease in Brazil. Thanks.
Okay. First of all, I'd like to thank Jean-Pierre and Gilbert for inviting me in the introduction, and also CAF, the Development Bank of Latin America, for inviting me to present this webinar on the key elements for tracking and monitoring the pandemic events. Okay. First of all, well, it should be in the third slide. I don't know what happened. I had some technical problem. It's not switching the, oops. Just a moment. Sorry for this technical problem. I don't know what happened because it was working just before the webinar is starting, but I'm not. I have not been able to change the slides. Okay, let's go for the slide number 4. Pablo, please. Number 5. Okay. Initially, I would like to give you an outline of my presentation. I will start my presentation by defining what is a pandemic. Next slide, please. Okay. What is an epidemic? The number of is the occurrence of a disease clear in excess of normal expectancy. But what is? How do we define that the cases are happening higher than the expected level? The number of cases indicating the presence of an epidemic varies according to the agent and the size of a population. For example, a single case of a communicable disease that not previously recognized in an area requires investigation, and a second case may be sufficient evidence to be considered an epidemic. For example, classic epidemics are initially identified following the occurrence of a small number of cases that you often use it to describe that a problem has grown out of control. The next slide, please. And what is a pandemic? Is an epidemic, therefore, is a disease that is out of control, that is happening in a number of cases higher than expected, that is occurring over a wide area, crossing international boundaries, and usually affecting a large number of people. Pandemics are generally classified as epidemics first. For example, the COVID-19, it was only considered as a pandemic in March 11 by World Health Organization. Before, it was only considered as an epidemic. And also, the occurrence of disease should be simultaneous worldwide. Next. Well, as I said before, the simultaneous worldwide transmission of disease is sufficient to define a pandemic. The influenza epidemics that usually happens every year are not considered pandemics. Why? Because the seasonal epidemic of influenza occur annually in the temperate southern and northern hemispheres, but not simultaneously. The outbreaks does not occur simultaneously. This is the reason why usually they are not considered as pandemics, only as epidemics, because when we have the outbreak in the north, we don't have at the same time the outbreak in the southern hemisphere. But in 2009, the H1N1 was considered as pandemic because there was a widespread transmission that that was observed in both hemispheres between April and September of that year. We had an epidemic occurring worldwide, caused between 100 and 400,000 deaths in the first year. Something that is very similar that we are observing now with the COVID-19. We have cases worldwide occurring simultaneously. Okay, next, please. Oh, well, brief description of COVID-19 pandemic. The disease is caused by a coronavirus. In humans, several coronavirus cause respiratory infections, ranging from the common cold to severe disease. As examples of more severe respiratory disease caused by coronavirus, we have the severe acute respiratory syndrome, SARS, we have the Middle East respiratory syndrome, MERS, and now the COVID-19. That COVID-19 is coronavirus disease 19. Why 19? Because the first case of this disease was observed in 2019. Next. Well, the timeline. The first, in December 31st, China reported a cluster of cases of pneumonia in Wuhan, and a novel coronavirus was identified. It was named SARS-CoV-2. In April 30, we had more than 3 million cases, confirmed cases, more than 200,000 confirmed deaths, and the disease was spread worldwide. Next. Here we have a map showing the situation in April 30. We can see that the disease is, we have cases worldwide, and simultaneously in North America, South America, Asia, Africa, Europe, Middle Eastern. Next. This is show clearly that is a pandemic. Well, how do we, the basic indicators for monitoring and tracking? Well, the first indicator is the number of laboratory confirmed cases of COVID-19. And we also have the number of deaths by COVID-19. When we talk about the number of cases, and also we have the number of hospital admissions by COVID-19 and the proportion of intensive care unit beds occupied. Next. Okay. The number of laboratory confirmed cases of COVID-19. Why do you use this indicator? First of all, most of the patients don't have, we don't have a clear symptom that defines the occurrence of the disease. Several patients just refer fever or fever and cough, and or fever, cough, and sore throat. Okay, muscular pain. Others, we also have other symptoms. For example, gastrointestinal symptoms like diarrhea, but none of these symptoms clearly define the presence of the disease. Therefore, we need a lab test, okay, to define the occurrence of the disease. But when we interpret the number of confirmed cases, we need to be careful, because the absolute number of cases provides a misleading picture of the burden of the disease and does not allow comparisons by country or regions. Why? Because the absolute number of cases of a disease depends not only on the attack rate of the disease or the how strong the disease is affecting a population. It's also affected by the base, the denominator, the size of the population that has been affected. If you have a small town in your country, maybe 10 cases must be much more significant than 1,000 cases in a large city. Okay, this is the reason why we also need to be very careful when we take these comparisons that only look at absolute number of cases. Okay, another issue, another important point is that, and we see this lots of time when we compare the data across over time. And also when we compare the indicators across different countries or regions, the number of confirmed cases is influenced by lab testing capacity. For example, in South Korea, they tested all individuals who had acute respiratory syndrome or who had contact with a confirmed case. Whereas in other countries, restricted laboratory testing to those seeking hospital care for COVID symptoms or those more susceptible, more prone to severe disease. This changing in the policy, this difference in heterogeneity, let's say, in the testing policies may produce different pictures. And usually, we like to say that when we analyze in any country the number of laboratory confirmed cases, we are only looking at the tip of the iceberg. We are not looking at the whole picture of the disease, because even in countries like South Korea, where they tested, let's say, everybody who was presenting symptoms of respiratory syndrome, even there, the cases that are not symptomatic, they are not tested. And there are some evidence suggesting that more than about 50 to 60% of the cases of COVID-19 are asymptomatic. Therefore, the people, they don't have fever, they don't have symptoms of the disease, and therefore, they are not tested. Okay? Next. Well, this is another problem when you look in this number of laboratory cases, when you look at this indicator across the time, okay? The change in testing recommendations in a region or in a country may change the numbers. For example, due to a high demand, if we have a high demand, and then we need to introduce a more stringent testing criteria, I could provide a false impression that the epidemic curve of the disease has flattened. Or, on the other hand, If you increase the testing capacity, we got more lab equipment, we increase our capacity. We may introduce less stringent testing criteria. And this could provide, of course, that we are testing more people, definitely, we get a higher number of confirmed cases. Then this could provide a false impression of increasing capacity or increasing the epidemic curve. Okay, next. Okay, now when we are going to compare the measures of occurrence of the disease by region of a country or among the countries, we should take in consideration the size of the population at risk, the denominator, as I said before. Therefore, when we try to make comparisons, is much more important that we estimate the attack rate. What is the attack rate? Is the risk of developing the disease in the population. Is the proportion of a population that experienced the disease over time. Okay, just a moment. I missed my presentation screen, Pablo. Okay. Could you come back to the previous slide, Pablo, please? Okay. And also we have the secondary attack rate. That's the number of cases of an infection that occurring among contact following exposure to a primary case in relation to the total number of exposed contacts. It's a measure of the contagiousness and useful in evaluating control measure. While the traditional epidemiological terminology include rate, it is often a proportion. Next slide, please. We can see here the cumulative data and the daily data of 2 countries, okay? I just took it. And what this shows, we see the absolute number of cases for Italy and Spain. Here are the absolute number, are the numbers, the totals, okay? It suggests that in Italy, you have the number of cases is higher, okay? But when you look at this same data, comparing the cumulative risk using, therefore, dividing the number of cases by the size of the population, we get a different picture. We see that the number of, at the end, the number of cases is slightly higher in Spain instead of Italy. Okay, this shows the importance of when we go to compare the regions or countries, we need to look at the denominator. Okay, next slide, please. Mortality rates. Mortality rates is the same as I said before. We should estimate, we should divide the COVID-19 deaths by the population at risk. Okay, it provides a more reliable picture on the magnitude of the disease, assuming that there is a good access to health service. And public and private hospitals report the deaths on a regular basis. What's the limitation of this indicator? It may be underestimated because of undiagnosed deaths or the severe cases who were not treated because the hospitals were overwhelmed. Okay, next slide. And we see that for mortality, the comparison, the absolute the risk and the risk showed more similar pictures, different from when we looked at the total number of cases, okay? But also, as I said before, when we are going to compare regions or countries, it's more important to work with the risk, not with the absolute numbers, okay? Of course, the absolute numbers are important, but if you are aiming at compare regions or areas, please work with the risk estimates, the proportion estimates. The incidence risk of hospital admissions of confirmed cases. This indicator is estimated dividing the COVID-19 hospital admissions by the populations at risk also, and provide a more reliable picture, assuming that most people with severe disease are admitted to hospitals and tested, that there is a good access to health service, and hospital admissions criteria and patient management does not differ significantly by area, because also, of course, that the incidence risk of hospital admissions, if this estimate is going down, it could suggest that we are being able to control the epidemic. But in the same token, if you have a more stringent criteria to admit a patient to hospital, this number may be going down only because we are not admitting all patients to the hospital. Therefore, we also need to take the context of these numbers, okay? Next, please. Okay. And the other issue is, if we take a measure to control the COVID-19 epidemic today, how long does it take to have an impact on the indicators? We have in the same day? No. Okay? We also need to take this into consideration when we look at the indicators, when we look at the numbers. It's very important. For example, the incidence risk of hospital admissions or mortality, okay, they are indicators of disease several days before, because we have the incubation period that the mean incubation period is 5 days, but it may vary from 2 to 14 days or even longer, okay? And also the time from the symptom onset to hospital admissions. It is estimated, as I said before, for example, that this indicator of hospital admission has a time lag of 12 days. Assuming that we have a median incubation time of 5 days, plus a 7 days, would be the median time that has been reported, this is the median time from symptom onset to hospital admissions. Of course, that you have cases where the hospital admission occurs 1 or 2 days after the symptoms started. But for most patients, usually it takes 7 days. Therefore, when we look at the hospital admissions, we are looking at the consequences of policies that were implemented, let's say, 2 weeks before. If we implement a lockdown today, please don't expect a change in these numbers of hospital admissions in the day after, okay? These numbers will start to change only after 2 weeks, okay? And for mortality, the time lag would be even larger. Okay, next slide, please. Okay, excess mortality. This is another indicator that has been used. It may estimate the real burden of COVID-19. It compares observed number of deaths with the expected base number of deaths based on the mortality rate in the previous years. It may overestimate the burden of COVID-19 if the health service collapsed and the people with other diseases were not treated because hospital became overwhelmed. We need, of course, that we need to be careful when we look at these numbers of excess mortality, because not all excess of deaths could be attributable directly to COVID-19. Of course, that are indirected, because if my health system is overwhelmed, maybe if I have a heart attack, I may get late to the hospital because I'm afraid of going to the hospital. Or if I get to the hospital and the emergency room is overwhelmed, may take longer to get to be treated. Okay, but it provides a picture on the real burden of the disease. Okay, direct and indirectly. Next. This is an exercise that I made, and we see that, for example, for New York, in New York, the excess mortality was 300% higher. Okay, in this from February to April. Okay, in other countries, the excess was much lower. Okay, suggesting that maybe the burden of the disease is not so high. Maybe the system was prepared. Okay, was able to deal with the higher demand. Next slide, please. What's telling us the epidemic curves? The epidemic curves show a cumulative frequency of new cases over time, based on the date of onset of the disease. These epidemic curves, every country has its own epidemic curve. Okay, here we see the curve for Germany. Okay, next. And also here we have another picture, another way of looking, because the epidemic curve, the traditional, show the cumulative cases, but it doesn't tell us how is the epidemic occurring. It is accelerated, it is slowing down. When you look at the daily cases, we have a different picture. This slide shows us that the number of cases is decreasing in this country. Okay, next. Here, this picture shows, we can see that by April 3rd, 30 in this country, we had a high number of reported cases. This, when you have an isolated peak in the number of cases, it suggested that we had some problem in the data in this country, in this area, okay? Because we wouldn't expect a huge fluctuation in the number of cases from one day to the other, okay? Next. Here is a different picture and shows, it suggests that the number of cases started to go down, and maybe the disease was spread to another area, and we have a new peak. Okay. Next. Okay. The change in the growth rate. This is another indicator that allows us to see two things. Is the disease accelerating or not? Okay. We have an increase in the number of cases or not. But also show us the fluctuation of the data suggested that we have bad data in this in this country or in this area, okay? Because we don't expect a huge, as I said before, a huge fluctuation in the number of cases from one day to another day, okay? For example, if you look at the first, in the top, the first country, it has a very, very good data. The disease is accelerating there, okay? You see that the proportion of cases, of new cases, the number of cases is increasing highly from one day to the other, but there is not a huge fluctuation. You can see here, for example, in the third country, it is accelerating. The data is not so good, but you can see in the middle that there are countries with bad data. As in the bottom, we can see that we see several countries, a small group of countries, sorry, that they are decelerating, they are slowing down the disease, it is under control, but we see that the bottom, there is a huge fluctuation. Definitely the data is not good in this country. Of course, that this indicator suggests that the data is not good, but it does not show the cause, the reason for the data not being good. Okay, next. What are the best practices for tracking and decision making about this kind of events? Okay. For monitoring COVID-19, we have three sources: laboratory data, therefore the number of lab confirmed cases, hospitalizations, and mortality. And also we have mobility changes that I will be showing later. Okay, next. Okay, mobility change. Here I have some graphs from Brazil. This is estimated by Google. It shows, for example, it provides an overall picture. It is used to show how visits and length of stay at different places changed compared to a baseline. The baseline would be when we started the lockdown. Okay, then it shows that, for example, these numbers shows that people are, compared to baseline, for example, are staying more time, high percent of the people are staying at home, but the retail and recreation decreased by 59%, transit station by 54%, and this data is good to estimate how is the adherence of how is the compliance of the population with the quarantine and the lockdown policies. Okay, next. Social distance and COVID-19 incidence. This slide, these are simulations, okay? And in the first slide, we have, in solid, we have the infected, in the dash, the number of cases, okay? If you have a social distance lasting 4 weeks, and you have no intervention, if you had no intervention, you had this number of cases, okay? If you have what is the impact of these policies with the impact in the number, in the reduction in the number of, in the infections, in the contagions? Okay, if you have in the red, we have a low adherence of the population to the social distance, okay? And in green, we have the highest. It shows, for example, a short-term social distance that lasts for 4 weeks. The curve, the epidemic curve doesn't change a lot if we had no intervention or if we have a certain grade of adherence. On the other hand, a social distance lasting for 12 weeks, we can clearly see that if we have a high adherence of the population to this policy, we are able to flatten the curve and postpone the occurrence of the disease. Okay, next. How do we estimate the extension of the infection in the population? Even for countries such as South Korea, the incidence of the disease is underestimated. As I said before, we have from 50 to 60% of, it has been estimated that between 50 and 6% of the cases of COVID-19 are asymptomatic. Okay, one of the strategies is to carry out population-based epidemiological surveys. Okay, next. Actually, we are carrying such survey in Brazil. Okay, we initially carried out. We started before in our province, Rio Grande do Sul, and now next week we start in the whole country. Okay, to conduct the service, it's very important to obtain representative samples of the country. Of course, that is very of an area. Okay, if in a city, of course, that when you talk about a province or a country, is very difficult and very time-consuming to obtain representative samples of the whole country or the whole province. What we did here is we followed the WHO guidelines and worked with the concept of sentinel sites. We pick up cities that are the siege of intermediate regions of the province, and we evaluated a representative sample of the population living in the urban area of these cities. We pick up these cities as sentinel sites of what was happening with the disease in the whole area. Okay, but it's better work with these estimates than, because there are some studies being carried out that are producing biased estimates, and you should be very careful when we look at status. Okay, for example, internet-based surveys. How can I do an internet-based survey for COVID-19? Well, I can create a website or a Facebook page and invite people to attend some place to give a blood sample for a test. Or I can take people found outside their homes shopping at essential business, such as grocery stores, and then test these people. But the people who are outside their homes, they are representative of the whole population? Probably not. Or, for example, I can take blood donors. I go to a blood bank and take the blood samples who are there and I'm going to test. They tend to provide biased estimates of the whole picture of the COVID-19 in the population. Next. How to measure the outcome? It's very important. We have PCR and antigen tests and antibody detection tests. The next picture. The PCR and the antigen tests, they provide a picture of what has happened in the first days since the onset of the disease. And this figure shows that after 14 days or 20 days, depend on the case, they tend to be negative. Therefore, this disease, these measures, they provide a picture of what's happened today, but it does not provide a picture, for example, of what was the proportion of the population that have had contact with the virus. These pictures are provided by antibodies. Okay, of course that the antibodies, they have, as you see, IgG and even IgM. They start the level. They start to rise the level between 10 to 14 days after the occurrence of the infection, whereas the viral RNA and the viral antigen that starts to raise in the first days after the contact with the virus. Therefore, viral RNA and viral antigens, these tests are very good for diagnosing the disease, but antibody tests are very good for telling us about the proportion of people who already had contact with the virus. Okay, they are not good for diagnosing. Sometimes I will have IgG positive and I am already without symptoms, and my viral load is 0. Therefore, I'm not more transmitting the disease. Okay, next. Okay, next. The proportion of infection in the population, and these tests, these antibody tests will give us this information. Okay, if I also measure the symptoms, I will be able to estimate in my area the proportion of symptomatic cases. And if I carry out repeated surveys, that's something that we are doing here, I will be able to evaluate the impact of the outbreak of control measures. Okay. And here we have some recommended sites, websites with information on the disease. Thank you.
Okay. Well, thank you. Thank you so much, Professor. This was a really enlightening talk. I think there is a lot of information. We will be posting it in our website also for permanent consultation by anyone who would like to see it again, or for the people who weren't able to make it today at this hour.
Okay.
So now I would like to invite our audience to ask their questions on the chat that is available on the website. You can write your questions, and we will be reading them for Professor to respond. Anyone would like to ask a question?
Okay, Gilbert, you asked what means active cases. Active cases are the cases who are the number of people who have the disease now. Okay, if you look at, for example, I didn't show these slides, but for example, in Spain or German, the number of active cases is going down every day. It suggests that the disease is slowing down. Okay.
So Dr. Oriana Gonzalez has asked a question. Do you think that new technologies like the contact tracing app launched by Google and Apple can play a role in controlling the current pandemic?
Okay. These contact tracing apps, they are, well, the contact tracing, it's an important strategy in areas where the disease is not widespread. Okay. And these apps, of course, that they assist us to identify who had contact with someone who developed the disease or presenting symptoms suggesting that has the disease. Okay. Another day I was talking with an American colleague, and he said, "Oh, here in some areas, we still have the opportunity for doing contact tracing, okay? Because the disease is not widespread, then we can use this strategy to trace the contacts of a positive case and try to identify whether or not they are positive also for COVID, and if they are positive, to put them in quarantine, okay? And then we can, with this, slow down the spread of the disease, okay?
Yeah. On that topic, maybe I have a question for Dr. Richards. So I believe that here in Trinidad and Tobago, where there are quite few cases, you actually did some contact tracing, but not necessarily with an app.
Our contact tracing is done through our primary care and public health physicians or the county medical office teams. So it's not really done through an app, but it's basically done with some mapping. It's done by the Office of the Principal Medical Officer, Epidemiology, in conjunction with the primary care and public health physicians for the area, and with the use of some mapping techniques as well, such as GIS.
Yeah, depending on the country, there are also some discussion about privacy, because in some places the people use cell phones or credit card information to try to trace where a positive case went, and try to what sometimes this is very complicated in terms of privacy information, but it's very important to, when you have a small number of cases, this is a very important strategy to try to trace the contacts and test these contacts also, because they can be asymptomatic. And for this, is very important to work with tests that try to detect RNA or antigen, not antibody tests, okay? To work with PCR or other antigen tests.
Thank you, Professor. There is another question from Gillian Edwards. So you spoke about biased samples. In your opinion, what is the most ideal sample pool?
The most ideal sample pool is we should try to work in Brazil. We use the Institute of Geography of the Brazilian Institute of Geography and Statistics. They divide the cities in census tracts that are areas with more or less the same size, and we random sample some of these areas, and in these areas we sample some blocks and sample some households. Therefore, it's a process that gives to everybody who lives in the city the same likelihood of being sampled. The problem with this biased sample is that, for example, if I go to a grocery store to do a survey, okay, if somebody doesn't go to the grocery store, the likelihood of being sampled is 0%, okay? And if the infection is different between who goes and who doesn't go, we have a biased estimate, okay? It's the same thing. Let's say, I'm going to work with people who is attending the health service. It's not the best estimate, okay? Also. Okay, you have a question from Andrea. The slope of the curve in Italy and in Spain, even so the number of cases are decreasing. Well, Andrea, this is a very tough question, okay? Because of course that now the number of cases are decreasing, and suggesting that the disease is under control. And then we are facing this pressure in Brazil, okay? Because we are in a certain level of lockdown, not so strict as in Italy and Spain, but we are in lockdown, and of course that it started to have pressure to ease the restrictions because we have economic impacts on the population too. Okay, and when we start to ease this, relaxing the social distance measure, if we don't care, if we don't slow down very, this relaxing, should be very slow. Something that, like in Spain, now you can go outside for walking in certain times, and you are going to observe how the curve is going to behave in the next following days. Then we're going to move to the next level of relaxing. This must be very slow, because we don't know if we have herd immunity already sufficient to protect the community. Basically, it seems that the level of infected people in the areas is not enough to say, oh, we can now open the community. Okay, then this implementation of the social distance, the relaxing of the social distance measures should be very slow, and also you should take care of the being very strict in terms of the policies with respect to protection measures against COVID-19. For example, should we wear masks? Should we disinfect the places? And should we avoid big agglomerations? Okay. Exposure to the disease may have harder effects on the people who get COVID. Yes, indeed, we are learning about this disease, about the consequences on the people and also on the health system. Because, for example, the severe cases or even the not so severe cases, what are the long-term consequences on lung function? And what is the impact of this in terms of rehabilitation needs? We don't know, okay? But we estimate that we also will have a huge impact on this. Okay.
I think there is one last question, maybe.
Okay.
In relation to the previous question, is what is the best curve to monitor the easing of public health measures?
The best curve is to look at the incidence curve, okay, the new number of cases. Of course, that as I said before, we need to be careful, because if, let's say, Trinidad and Tobago implement strict social distance measures today, they cannot expect that tomorrow they will have an impact in the decrease of the number of cases. It will take, let's say, 2 weeks, at least 1 week, because we have, let's say, the mean incubation time period is 5 days, and then we start to have the symptoms. You go to to some health facilities to get the test, but also you need to process the test. Let's say it will take at least 1 week. Okay, but the new number of cases is the best indicator to measure the impact of these policies. Wow. Definitely, yes. I would say when you decide to reopen, for example, the airports, it's definitely advisable to if possible, to quarantine the people that are coming from high-risk countries. Well, now, what is a high-risk country? I would say almost every place around the world, okay? We should try to quarantine the people. At least we should identify the people to ask them where they are going. Because, for example, if someone is going to a city, okay, where you have no cases, and we should tell the local health system, it's a potential source of, please look at the contacts. But these people should be advised to be in quarantine. And if they need to go out home, to wear masks, okay, definitely. There is any evidence? I would say no, Pablo. I would say that there is no evidence that COVID will be seasonal. For example, now in Brazil, people usually say, oh no, this virus, this respiratory virus, they like the cold weather, the winter. Okay, one of the areas in Brazil where you have the highest proportion of cases is in the Amazonia, in Amazonia province, in Manaus, that's the capital of the Amazonia, in the middle of the jungle, in the hot and humid area, okay? Yeah. So this is, I would say, the virus is around us. Probably we have like more than one wave of the disease, because of course we have a first hit, then we have some control measures, we decrease the number of cases, probably have a second and a third wave. Then we need our epidemiological vigilance must continue, even if the number of cases really goes down. Okay, this is very important. Let's say even if I have for 2 or 3 weeks in my country, I have no more cases, reported cases. Oh, should we stop completely the vigilance? No, we should continue to be active.
Thank you so much, Professor.
Okay. Oh, there is a last question from Frederica. What would you recommend are the monitoring and health capacities needed by going to think about easing? Okay. I would say that 2 important indicators are the number of cases, new cases, it is increasing or decreasing, okay? And what is your hospital capabilities? What is the proportion of hospital beds that are occupied? Okay, this is also an important indicator. Because sometimes the proportion of cases may be going down, but if our hospital beds and intensive care units are occupied, you are not able to easing the social distancing measures, okay? But if your curve going down and in the proportion of hospital beds available is increasing, you can now start to think about easing social distance measures.
Very good. Well, thank you so much, Professor.
Welcome.
I would like to thank everyone who has attended today. I think this was very, very useful session, and I have received feedback that we have had a good attendance. So this will just be the first one of a series of events we hope to carry out to continue our support. Just to say that CAF remains totally committed to helping its member countries in protecting themselves and in becoming more resilient to this pandemic that is not whose end is nowhere near yet, unfortunately. And I would like to leave the final words to Dr. Richards.
Okay, thank you very much, Bernardo, Pablo, for doing organization, and of course our CAF representative, Gianpiero in Trinidad and Tobago. This was an extremely useful session. I am myself a public health. I think it was in terms of developing our health systems. Are you all hearing me clearly?
No.
Hello? Are you hearing me? No?
No.
No. Now it's working.
Nope. Are you hearing? No? Hello?
Hello? Hello, Dr. Richard?
Are you hearing me?
There are
Hello,
some
yeah.
issues with the sound, apparently.
Yeah. The
We
internet connection.
couldn't hear you.
Yeah.
Are you hearing me
Yes.
better now? Okay.
Yeah.
So great. Probably a little drop in connectivity. Thanks again to the CAF team and to Bernardo and to Pablo for your assistance in this education session. Of particular interest to us was how the information was aligned, was the alignment of the information shared by Bernardo from an epidemiological context and how it impacted or how it can impact on government policies. We are in the process of really developing future technical cooperation agreements, and we look forward to having CAF here. Having the cooperation of CAF already from this meeting. I already have 2 other ideas for sessions that we would want to have collaboration
Excellent.
with CAF on that I will email Gianpiero as soon as I'm done on this meeting. Also,
Excellent.
what was very useful was the question and answer session. I think all questions were extremely relevant and provided great information and detail to us in terms of how we move forward. And lastly, the online platform, I must say, has been very user-friendly. And the fact that this information will be shared on the CAF website is extremely useful for those physicians who could not join today. So in closing, I would like to thank all the persons who assisted in organizing this program. And I look forward to our future collaboration for meetings in the near future.
Certainly. Thank you.
Thank you.
Thank you.